welcome to CFTR 4D, ahead of the curve. I'm very impressed that anybody who got out of bed this morning, Dean, I think you should get them 2 breakfasts this morning. Very impressed. We have a fun morning. I think you'll enjoy both the technology and the talks, hopefully. And let's go ahead and get started. That's good. So this was put together by Johns Hopkins CME Department and DKB Med. That's sponsored by Vertex supported this, although basically the faculty that you see are the ones who put together this program entirely on our own. So one of the key things here is when you leave, you can actually get a jump drive that has 3D on it, but the glasses you're wearing don't work with it. We need those glasses back. We'll actually give you your own glasses to go. That's actually, they're going to charge us €100 for every set of glasses that leaves here, so please give those back to us. We're going to have question cards. If you have questions along the way, please give those to some of the people who will be collecting them, and we'll be happy to go over those. So this is actually flying into the surface of the lung. I know it feels a little bit, gets seasick here, but hang in, it'll get better. This is actually what's going on at the surface of the lung, where we know that the airway surface liquid layer plays a crucial part of protecting the lung normally from particulate matter and from bacteria that's landing on the surface of the lung. This airway surface liquid layer is controlled by the role of CFTR and ENaC. But this balance allows this healthy liquid layer. Now we're going to call out, look specifically at CFTR right here in front of us, with CFTR playing a key role in chloride transport out. Obviously, problems with that are going to lead to CF. That ENaC also controls sodium intake. That this balance between CFTR and ENaC is the thing which determines the thickness of the airway surface liquid layer. And really, it's that balance which leads to healthy lungs. When we have mutations, particularly in chromosome 7 at the CFTR locus, this leads to dysfunction of CFTR, leads to problems with the airway surface liquid layer, and leads to this disease that we call cystic fibrosis. So what we're going to be talking about this morning, I should introduce myself. My name is Mike Boyle. I direct the adult cystic fibrosis program at Johns Hopkins and been very involved with some of the therapies development that are going on in cystic fibrosis right now. And what we're going to do, first of all, is to talk about these different classes of mutations and how the different treatments in the future are going to be geared towards treating those specific classes. So this is our learning objectives. I'm going to talk about class 1 and 2. Peter's going to talk about class 3, and Chris is going to talk about classes 4 and 5.
Je m'appelle Gerault, j'ai 17 ans. J'habite à Landen, qui se trouve dans la partie flamande néerlandophone de la Belgique. Et j'ai une maladie qui s'appelle la mucoviscidose, et moi j'ai le type 2 de cette maladie-là.
Et je suis curieux.
Comment ça affecte ma vie de tous les jours? C'est assez difficile. Enfin, j'ai toujours eu difficile avec l'aérosol, le masque, la prise des médicaments.
Tu peux le faire comme ça.
Mes parents sont souvent derrière moi, donc m'aident à retenir, à me rappeler de bien prendre mes médicaments après chaque souper. C'est assez bien, parfois un peu embêtant, j'ai tendance à leur dire oui, arrêtez. Je sais que je dois le faire, parfois j'ai pas envie, mais voilà, c'est obligatoire. Une de mes passions générales, c'est principalement les voitures. Mes parents ont décidé de me faire un cadeau pour la Saint-Nicolas. Et c'était quand j'avais 5 ans, je pense. Et quand j'ai vu ça, c'était vraiment le cadeau, le plus beau cadeau que j'ai eu de ma vie. Je roulais tous les jours dessus, qu'il fasse beau, qu'il fasse pas beau, qu'il pouvait pas pleuvoir, pas vraiment, mais il pouvait neiger, j'allais toujours sur mon go-kart. Le go-kart est une de ces choses qui me fait un peu oublier la maladie. Je disparais, qui me libère vraiment, donc qui me fait oublier un peu la maladie. Tous les 3 mois, je retourne à l'hôpital pour faire donc, un relevé. Donc, je fais une fonction pulmonaire pour voir comment tout se passe. Myriam, donc la kinésithérapeute de Louvain, elle est très sympathique. J'ai une très bonne relation avec elle aussi.
Très bien.
Que les sécrétions sont bien remontées, on sent vraiment une différence. Mais bon, maintenant j'ai déjà 17 ans. Après un certain moment, on a d'autres choses à penser. On a travaillé, on a gagné sa vie, vivre une vie de famille peut-être plus tard. Donc je ne pense pas que c'est quelque chose que je vais faire pendant toute ma vie. Mais je serais content si je pouvais le transmettre à ma descendance, si j'en aurais une. Et oui, je crois que c'est quelque chose que j'aimerais bien leur faire faire et leur donner envie de faire.
Well, Gerault actually has a class 2 mutation, F508del, which is a dysfunction of CFTR that's caused by misfolding. What you see here is a misfolded CFTR that cannot insert into the apical membrane. That causes it to break down, to be degraded, so that you do not have functional CFTR. It leads to overactive ENaC, as you can see here, and dehydration of the airway surface liquid layer, which leads to the cystic fibrosis phenotype with thickened mucus and infection that we see. Now in the future, 809 and other similar correctors are going to correct that folding and allow insertion into the apical membrane and restoration of chloride transport. Optimizing the chloride transport will also be using other things called potentiators, such as Ivacaftor, and hopefully treat this. Now, class 1 mutations, which we're going to talk about as well, are caused by stop codons, in which there's premature truncation, no meaningful protein made, the incomplete protein is broken down, so there's no CFTR up at the cell surface. In the future, we're going to come up with therapies which allow read-through of these stop codons. This will allow drugs such as Delorean or other class 1 treatments to make a complete CFTR protein, get that CFTR up to the surface, and go ahead and fix the CF phenotype. So what we're going to do is talk about class 1 and class 2 treatments. We're going to actually do one other 3D video that talks a little bit about cystic fibrosis in general right after this. And, but we're going to give you an update right now, and hopefully not just focus on things you've heard before, but go ahead and talk about some of the newer things that are going on. Just as a quick review, remember that most of the mutations that are causes of cystic fibrosis can be classified into basically 6 classes. We're going to focus on the 5 most common, with those all leading to dysfunction of CFTR, so that it's not functioning as it sits up at the surface of cells that line our lungs. So those class 1 mutations are those, like we said, with stop codons, so there's no protein that makes it up to the surface. Class 2, the most common, which we're going to talk about right now, has poor trafficking up to the surface because of misfolding, and we're going to talk about classes 3, 4, and 5 a little bit later on. Class 2 is caused by this block in processing. It's the most common, so that 87% of all individuals carry at least one F508del mutation. We see that this is the breakdown, so that about half of those patients carry 2 of the F508del mutations. About 39% carry at least 1, and it's only a small minority that carry no F508del mutations at all. It highlights why it's so important that we come up with therapies for this. So where are we at with this? We're going to be talking about these meetings and upcoming meetings, correctors specifically designed to fix this trafficking problem to get the CFTR up to the surface. The ones that we're hearing about right now is called VX809 or Ivacaftor. We're also going to hear for the first time some exciting new data about VX661, which is basically the same class of corrector. And these are, again, designed to treat this most common type of CFTR mutation. Let's just quickly review. I know we've seen this slide before, but it's important. The whole point of treating F508del is to do 2 things. First of all is to try to get that trafficking problem fixed so that we get more of the protein up at the surface. And we know that 809 does this. We see this when we actually do chloride studies and we check in a dish. We see the treatment with 809 alone actually increases the amount of chloride transport because it increases the amount of CFTR at the surface. Adding another potentiator such as Ivacaftor, which we'll hear more about later, which actually opens that channel, makes the CFTR that makes it to the surface through this corrector even more effective, so that the combination of 809 and Ivacaftor leads to a greater amount of chloride transport and to hopefully correction of the CF phenotype. Let's talk specifically about the data that we have so far with these correctors. This is from the Cohort 2 part of the 809-102 study. Just as a reminder, this study was done in two parts. The first part was done as monotherapy with just 809 alone, but we knew that we were going to need to add something to that 809 to get maximum effect, this combination of 809 or Ivacaftor along with Ivacaftor, this potentiator which increases the channel opening time. This was done in 3 different doses, and each for about a month at a time to be able to look at some of the effects. And obviously, we don't have time to go through all of this, but I'm just going to highlight some of the probably more exciting data. In some ways, almost as we expected, monotherapy did not have a big effect by itself. This is looking at absolute FEV1 in 2 groups, the group that received placebo in yellow and the group that was receiving 809 alone. And this is the individual patient data. That during that first 28 days, there was really no difference between placebo and treatment. But let's look what happened in that second group during the time of treatment with a combination of 809 or the Ivacaftor and Ivacaftor together. You can see that the treatment group in general had significant improvement in their absolute FEV1, with about a quarter of those patients having more than a 10% absolute improvement in FEV1, and over half of them having 5% or more. The other thing that we're going to talk about at this meeting, and we'll be presenting this later on today, is the results of Cohort 3. Cohort 3 was specifically designed to test an even higher dose of the 809 to make sure that we were going to be able to optimize treatment for that group, that very important group. The results we just showed from Cohort 2 were convinced us enough to make us move on to Phase 3. Those Phase 3 trials are going to be ongoing. This is actually the data from Cohort 3 with a larger dose. So rather than the 600 once a day, which we were just looking at the data for, this is actually a 400 twice a day. And this is just another way of looking at the monotherapy period and the combination therapy. Now, there's a couple things that jump out. First of all, the combination therapy actually had almost identical effect in terms of improving FEV1. Again, this is absolute change in FEV1, very similar to what was seen with the 600. The one thing we are going to keep an eye on that's sort of being highlighted is that monotherapy by itself certainly is not helpful, and it's not something that we're going to be testing any further in Phase 3. So the ongoing Phase 3 studies are literally just getting started. We enrolled our first patient in it the day before yesterday. Each of these trials are to test the 809 Ivacaftor combination, both at the 600 and the 400 twice a day dose. They're basically 2 very identical treatment trials with a few differences. Each of these are going to have 500 patients in them. A very large Phase 3 study to look for FEV1 effect. 6 months of treatments looking at FEV1 and other clinically important outcomes. And this is a 2 to 2 to 1 randomization to either the 600 a day, 400 twice a day in combination with the Ivacaftor or a matched placebo. The thing I'll mention as well is 661. We're going to hear more about that from Scott Donaldson later on today. 661 has very similar characteristics to 809. There's a few different characteristics in terms of pharmacokinetics and interactions with other drugs. This was studied in 128 patients recently. We're going to hear about those results, like I said, later on today. The treatment design was a little bit different than the... It actually did 2 different groups, one a monotherapy group and one a combination, rather than having a patient go from monotherapy to combination. And here's the key take-home message. We actually saw a significant improvement in FEV1 at the highest doses of 661. The one thing I will draw your attention to, and probably pay attention to this throughout the meeting, is whether or not relative change or absolute change in FEV1 is being reported. The FEV1 data for 661 will be reported as a relative, so these numbers are going to look a little bit larger, perhaps, than the absolute. But the bottom line was that we again saw this combination therapy with 661 and Ivacaftor making a significant improvement in FEV1. This really, I think, is very encouraging that this combination effect this combination of therapy is going to be helpful. We just have to find the exact right agents for this. I will mention that there's other correctors that are being developed at the same time. Some of this is coming from other companies, such as N30 Pharma. They're developing actually two different agents. The N6002 is one that's ongoing trial. It's an IV agent. They also have an oral agent that they're developing. Vertex is developing another first-generation corrector called VX983, which should be getting started later on this year. And CFF, the Cystic Fibrosis Foundation in the United States, is working with several different companies to try to speed along the future development of these other correctors. Now, why is it important to get other correctors? I think we're starting to realize now and understand a little bit more about how these work. This is a recent paper that came from Nature Chemical Biology. I just wanted to highlight what we were learning from this. The bottom line is that we know more and more about the structure of CFTR that tells us the key part of stabilizing the folding problem of F508del has to do with the nucleotide binding domains, NBD1 and NBD2, and how they interact with the transmembrane domains in CFTR. The problem is that F508del mutation sits in NBD1 right in the middle of this interaction, and is the thing that leads to this destabilization and the breakdown and misfolding of this protein. The key thing is that we know that if we attack this and try to stabilize this with multiple agents, we'll actually get more effect than just a single agent. So in the future, it's been proposed that we actually start thinking about different classes of correctors. So those that actually stabilize nucleotide binding domain 1 and where it interacts with this membrane spanning domain would be class 1. And that's actually VX809, it's VX661, it's the 983. They're all part of this same class. But we know that there's other correctors that can work on other parts of CFTR that work, some work specifically with F508del and where it interacts with the nucleotide binding domain to help stabilize. The key thing is in the future we're going to probably want to use multiple different classes to try to optimize our correction of CFTR and get even more clinical effect. So let's talk about class 1 mutations. Class 1 mutations are those, again, where there's no CFTR making it up to the surface. And this is usually because of stop codons, any of these mutations which end in X for the most part. Now, we'd like to be able to talk about a lot of new things. This is an area where we probably need more development. So I'm going to review what we have so far with Delorean. We know Delorean, some of the data was presented last year, was studied. This is a read-through agent, which allows this ribosome to read through the stop codon. Unfortunately, in the big phase 3, Delorean missed its primary endpoint of FEV1 at 48 weeks. But there were some positive trends which make us think that this approach could work, even if it's not Delorean. Just going to look specifically at the data. This is actually the FEV1 data from that trial. You can see that in the treatment group of Delorean, in general, there actually seemed to be a little bit of demarcation here, although not enough to reach significance and approvability as a drug. And then the thing that was particularly intriguing is we know that the site where Delorean and some of these other read-through agents work may be interfered with by certain other agents. One of those is aminoglycoside. And so this is just a post hoc analysis looking at those patients who are not taking aminoglycoside versus those that were, and that the group that did not have this other agent to potentially interfere with this interaction actually had a pretty significant difference compared to placebo. Again, sort of hinting that if we could find the right agent, we might be able to really use this approach to treat the class 1 mutations. So if the key reason why we're sort of focusing on these first two is because if we could address these two, obviously class 2 is the most, 87% of patients have at least one class 2 mutation. 12% have a class 1 mutation. If we could address these mutations, we'd be able to address the majority of individuals with cystic fibrosis.